in from across the country, from Garissa to Magori, from Meru to Baringo County. So welcome one and all to our topic today, managing difficult conversations at the bedside. We have three wonderful speakers. We're going to hear some challenging cases from them. And our first speaker is Professor Janet Lefroy, and she is going to start us off and introduce herself. Let's cue up her section. And Janet, over to you. As a reminder, let us remember that we want to learn together. So please write your questions down and be able to post them in the chat box. We want to learn from you. What's your big takeaway today? Let's move directly into Professor Janet Lefroy's session. Thank you. While they're queuing that up, I want to welcome, I see people joining from Mandera, Bogoma County. It's wonderful to have you all with us today. Technical team, we're waiting for you.
Thank you. There was a small technical error, but it's being queued. Thank you for your patience.
You know, as people are continuing to write where they're from, why don't you also add a comment about what made you decide to join this session today, the session on managing difficult conversations at the bedside? We love to hear from you. You know, as they are continuing to work to queue this up, I will just say a word or two about our additional speakers. You've had a chance to read through Professor Janet Lefroy's bio, and we are looking forward to hearing from her. She is live with us today, and Janet, if you're able, why don't you unmute and share a little bit about how you got interested in the topic of difficult conversations at the bedside?
Thank you. So hello, everybody. I'm really pleased to be with you this afternoon. I'm a general practitioner in the UK. So I'm a family doctor, and we do have difficult conversations, maybe at the chair side or the couch side or in people's homes. I've been really trying to work out how to do these better. They're always difficult, and they'll still be difficult even if you do them well. But I always feel there's one chance to get it right. You can't unsay what you've said. And so that first I've been doing some reading and found really helpful advice and research that other people have done that I wanted to share with you today.
Thank you, Janet. Let's go ahead and share the presentation. Tech team, are you able?
Hello, I'm Janet Lefroy. I'm a family doctor in the UK. I'm lead for consultation skills teaching and learning at Keele University School of Medicine, and I'm a member of the Kenya UK Health Alliance. I'm pleased to offer you some communication skills for those difficult bedside conversations, such as breaking bad news and when you are in conflict. Difficult conversations will be difficult, whether you do it well or not. Bad news is still bad news, even if you have it explained to you in a perfect way. But the patient will remember forever and will tell other people what the doctor said, so you have one chance to get it right. Conflict is going to feel like a battle, where one of you wins and the other loses. But you can use skills and attitudes which will turn that into a win-win, where maybe the outcome is not exactly what either of you initially thought it should be, but the compromise is acceptable to you both. There are two toolkits which have been found helpful in clinical practice and which we introduce to our medical students in communication skills classes, so that they can get their difficult conversations right first time. First, I'll tell you about a toolkit for breaking bad news. 23 years ago, these American and Canadian oncologists developed what they called a protocol for delivering bad news. I prefer to call it a toolkit because you may choose to use each item and use it more than once, or you might leave one out if not appropriate. The reason they developed this was because they realized that although patients generally want to be told the truth, the physician experiences barriers to breaking bad news, mostly barriers within themselves, feeling that they are hitting the patient over the head or dropping a bomb. They conducted a survey which identified several stresses in giving bad news. 55% ranked how to be honest with the patient and not destroy hope as most important, whereas dealing with the patient's emotions was endorsed by 25%. Finding the right amount of time was a problem for only 10%. Fewer than 10% had had any formal training in how to break bad news. Since there is one chance to get it right, and it matters so much to patients, they devised this guidance. So here is the Spikes toolkit. First, S, setting and preparation. Arrange some privacy, if possible, and enough time. Involve significant others. Get the tissues. Sit down. Make eye contact. And in preparing for this, think about the information you're going to give. Have you got it? And think about their likely questions. Do you know the answers? P for perceptions. The patient's perception. You need to know their starting point. I ask, what's your understanding of your medical situation so far? Or what have you been told about why you had the MRI scan? Based on this information, I can correct misinformation and tailor the bad news to what the patient understands. Invitation. This is you getting their invitation. Is it okay to give you the information now? Or is there anyone else that you want to be here before we tell you your test results? Are you the sort of person who wants every detail or just the main diagnosis and the treatment plan? It may not be necessary to ask your patient, but you can't unsay what you've said. So if they didn't want it done now, or wanted you to tell their son and not themselves, it is worth asking for the invitation. And this is also a way of getting them to prepare themselves for unwelcome news. If it were good news you were about to deliver, you probably wouldn't ask them whether they want to hear it. K, the skills of how to impart knowledge. The knowledge which is the bad news. This is developed in the next slide, and then we'll come back to the E and the S of spikes. There are quite a lot of skills in giving knowledge, and we teach these to our medical students for giving any information, not just bad news. So firstly, the knowledge you want to give is the gaps in the patient's perception, which you've discovered from your initial discussions that they need to know or want to know. If you think the bad news will be unexpected, use a warning shot. For example, "I'm sorry the test results are not good." This is kind to the patient because it gives them a moment to prepare themselves to receive the bad news, and also shows that you care about them. Chunking and checking means give a chunk of information and then check whether they have questions or need time before you give the next chunk. Avoid medical jargon. Use the terms which the patient used when you were getting their perception. Diagrams and written information can be helpful during a conversation, and your patient will probably take them home to explain to their family what you have said. Ask the patient to teach back. This helps you to be sure that they've understood the important points. And a good way to do this is to say, "I want to make sure that I explained the information well. Can you tell me the main points back?" Then, if they've misunderstood, you have made it clear that it's your fault, not theirs, and you can find new ways to explain what they may have missed. Make sure you give them the opportunity to ask their questions before you move on. If they have questions, they may not be able to listen to what you're saying next until those questions are answered. Sometimes the information we have to give is more about risk of bad things happening rather than breaking bad news. And this can be quite difficult to do well. For example, if I say you have a 25% chance of getting side effects from this chemotherapy, do I mean that a quarter of people taking the chemotherapy will get side effects, or if you take it 4 times, you'll get the side effects once? So to be more clear, it would be better to say, if 100 people took this medicine, 25 would get side effects, but 75 would be fine. And it is good to explain the risk clearly, but include the positive side also, the chance that the bad thing may not happen. So, for example, out of 100 people having this operation, 95 will be problem-free post-operatively, but 5 may have this post-operative complication. And some people find a visual representation of this helps them. Finally, use your denominators consistently. So if you say, if we treat your condition, you will have an 89 out of 100 chance of improvement, but the treatment has a 1 in 25 chance of side effects, our patient may find that confusing. It's better to say, out of 100 people with your condition who we treat, 89 will be better and 4 will get side effects. Okay, so let's return to our spikes toolkit. We've given a chunk of information, the knowledge. Now let's think how to use the E tool, exploring emotions and empathizing. We'll do this when appropriate as part of our chunking and checking, giving them time to react, asking maybe, "How are you feeling?" or "I can see you're worried." and using verbal and non-verbal communication to reassure and empathize with them. The strategy is a clear plan. If you don't know what the plan is, maybe you should wait to break the bad news until you do. However, sometimes you'll be asked for the results before the plan has been made, and some patients need time to digest the bad news before they are ready to discuss treatment options, especially if these are going to be complex and involve choice. In these instances, the strategy is that we'll meet again to discuss treatment and set a time for that if you can. The summary should be the main points that you want the patient to take away with them. Ensure there's some hope in the summary. You might provide a written summary. And finally, you will ask again whether they have any questions. These may be multiple, so when you've dealt with one question, ask, is there anything else you want to ask? And keep saying that until they say no.
You know, one of the things that I found so intriguing in this first part of Professor Lefroy's presentation is the way she aimed at E for emotions. Managing that emotional aspect is so important. As our tech team is queuing up the next segment, I'd like to ask you to write in the chat box about what works for you in supporting patients' emotions during the difficult conversations. And as people are replying, we will look forward to the next section as soon as it is ready. You know, as I'm reading people's responses, I think this one about having the patient come with a loved one is a great way. Thank you, Dr. Lydia, for that suggestion. Having patients come with a loved one really does help them engage and manage those emotions when there really is bad news and provides a great amount of support. It's wonderful to see that people are excited about being here and learning. Tech team, let's go on with the next segment. You know, I like John's response on managing emotions, saying, please come and sit down here with me. Great idea. On we go. I am not hearing the video associated. Can you turn it up, please, tech team? Tech team, we're missing audio. Can I get you to respond, please?
Okay.
Technical team, we're going to have to take a moment because we're missing the audio completely. Nelson, can I get you to reply? Thank you.
Yes.
We missed the audio on that. Can you get it to work?
Okay, just a second.
Now let's move on to those difficult conversations when
Is the audio and the video on now?
That was working correctly. Continue. Thank you.
you find yourself in conflict. I'm going to introduce you to a toolkit for managing conflict. This will be useful when you're not agreeing with your patient or their relative about what should be done, but it's also useful when you're needing to negotiate with a colleague or outside of work. Other negotiation skills toolkits exist, but we have found Manchester United works for us, and I'll take you through it. This is not published as far as I'm aware, so I have provided our version to your organisers, and you're welcome to use it with acknowledgement. U stands for understanding. Aim to understand the other person's problem. Allow them time to express their view. Use open questions. Use active listening skills, so your body language, but also reflecting back what they've said and summarising it. Identify and respond to their verbal and non-verbal cues. Accept that the other person has a right to their views, even if their beliefs and attitudes may seem odd to you. Imagine how you might feel in their situation. Avoid making assumptions about their views, always check. Show that you understand their feelings and thoughts by demonstrating empathy. Recognize that other unrelated issues may interfere with both parties' feelings and thoughts. For example, what's going on at home for you or for them. Aim to have them understand your position too before looking for solutions. N stands for non-negotiable issues. There might be areas where neither party are able to concede ground. Identify and clarify these points. Being specific about this helps in negotiation. Demonstrate your understanding by summarising or paraphrasing. So if they are absolutely not willing to have an operation, then there's no need to negotiate about that. I stands for identifying common ground. There may be areas which you can all agree on. Identify, clarify, and acknowledge these. One phrase which I find helpful in clinical practice is, "We all want what is best for the patient." This is usually true, or certainly should be. T stands for tensions remaining. Identify, clarify, and acknowledge the specific differences or sticking points that remain between you. E, explore possible solutions. Tentatively float your possible ideas, exploring the advantages and disadvantages of each. Encourage the other person to come up with options as well. Saying, "I wonder if we could," is better than "you should" or "why don't you." And D, decide together. You should now be ready to agree a plan. While you're negotiating, there are a few other tips that can be helpful. If you feel in danger, keep a safe distance. Are you closer to the door than they are? If you might be attacked. Stay calm and collected and try to involve others. One other person is often better than too many. Acknowledge the emotion and the legitimacy of the emotion if it is legitimate, and you may need to ask about it. How upset or concerned have they felt? Apologize if appropriate, but avoid blaming anyone. When you're apologizing, acknowledge what happened and identify any sequelae. Explain to the patient the context of how it happened, and if you don't know, acknowledge that, but reassure them that it is something which will be investigated and the patient will be kept informed. Express remorse. Say, I'm sorry this has happened. I've learned from this and in future I will. And it may be helpful at this stage to empathise with them, recognising the impact of the mistake on the patient. Demonstrate active listening non-verbally by good eye contact, nodding. Use open questions to identify the reasons for their upset and explore with them what options are available. It may be appropriate to acknowledge the imperfections associated with treating patients. And there are some things not to do. Try not to interrupt or reprimand the person you're in conflict with, and don't get angry with them. Don't deny the reality of their point of view or defensively challenge their interpretation. Usually it's best not to use touch to pacify them. That often could feel like an attack in this situation. Don't copy their aggressive body language, and don't use your body to block the person. And finally, let's think about complaints. Complaints can feel stressful and time-consuming. No one likes getting one. They may feel like a personal criticism, but we must try to learn from them. Patients may not be medically trained themselves, so they may not understand the reasons why decisions were made or how it feels to be a health professional providing care with limited resources, staffing pressures, and the complexity of care being provided. Some studies done in the UK Health Service give us the following information. Most patients complaining are not seeking financial compensation. They understand that everyone makes mistakes, but they want their concerns to be acknowledged and understood so that the same thing doesn't happen to other people. 72% of complaints were as a result of difficulties in communication. So you can see how vital good communication is. Complaints, we are told in the NHS, complaints must be acknowledged within 3 working days.
Thank you, Professor. It has been really interesting looking at the toolkit, learning about the ways that we can use one or more of the tools you suggested. And as you were discussing the issue of complaints, I can introduce our next speaker. Mr. Paul Ndungu has had tremendous amount of experience at the front line. He's a registered nursing officer, a patient-centered and quality specialist at Kenyatta National Hospital, and he's going to bring to us a case as well as talking about things that have worked during these kinds of conversations. Mr. Ndungu, over to you.
Thank you so much, Dr. Mary. Allow me to share with you the case of KK, 39 years male, who presented with difficulty in breathing, seizures, was also in a semi-coma. A diagnosis of aspiration pneumonia was made and admitted in the medical ward. Treatment commenced, was put on oxygen, antibiotics, and anticonvulsants. Further investigation showed a brain tumor, and further review by the neurosurgical team came up with an inoperable brain tumor based on where it was. Further interventions that were done on KK while still in the hospital. He was put a VP shunt to reduce the intracranial pressure. And a clinical decision was later made for home-based palliative care. Next slide, please. So like Professor has said that sometimes we are faced with difficult conversations, and most of these arise as a result of conflict, and most of them are related to education. So what worked for this case, and you also realize that in our healthcare system, by the time such a decision is arrived, the patient has stayed for quite some time in the hospital due to the nature of the investigations that need to be done, the many reviews that need to be done also, so that we arrive at a decision. So patients have their expectations, especially the family, now that this patient was in a semi-coma, and the clinical picture. So one of the things was to break the bad news that this is where we are. And one of the things that really worked well for this patient, we were able to arrange for a family conference. And the advantage of this is that we asked the family members, who would you like to come and receive information? Who would you like to be present? And for this information, then we tailor it in a compassionate way, and we also deliver accurate information. Help the family understand and cope with the news that whatever they were anticipating, they had high hopes that their next of kin will be treated. Now we are saying can only be nursed at home. So we allow the family to process the news. And this is not a one-off thing. We do several. For this case, we were able to hold like 3 families. And then the reason for this is that we allow the family to go and digest the information. We come back, we give them more, so that we don't bombard them with a lot of information, and in the process we lose them. The family conference is also done in a simple way, devoid of medical jargons. And in this case, because brain tumor, the surgeons can be able to illustrate with a diagram and show exactly where the tumor is and why they are saying it is inoperable. The other important thing that comes up is that we know we come from various cultural backgrounds, and we are all very interested when we bring someone to hospital. So everyone wants to know what is happening, what is being done. So in this case, we are able to involve the family in these family conferences. They are able to understand, ask questions where they are not understanding. And the most important thing is that we also want to bring the aspect of shared decision making, where we value their voice and asking them what matters in this case, what matters for KK. So we want to align the goal of care with what matters to the family. So we ensure that this exists. The resources that will also be needed when the patient exits hospital, we must discuss, because when we are saying about home care, home-based care, we know there must be someone who is taking care of this patient. There is feeding, there is toileting issues. So we want the family to understand so that they can pool resources and continue with the care and strive for a common position. We also want to issues of disagreement, where people feel so and so decided for this patient, and that was not the right decisions to make. So we want to bring everyone on board so that as they are making decision, it's corrective, no blame game. The other issue about family involvement is that we slowly teach the patient, especially when we are doing the nursing procedures. This is a patient, we said, who has a PEG tube. We want to show the family how this will be done at home. Sometimes as healthcare workers, we may assume how we do it easily and the rest time it takes. But for this family who have never done these procedures before, how will it look like when they... So we want to teach them slowly by slowly. We want to show them the medications, how they will be given through the PEG tube. We also want to teach them the danger signs that warrant them to seek immediate hospital attention when they go home. So this is done between the family at the bedside. So the nurses are able to perform the procedures, and they invite the family to perform the procedures together. So they'll be able to show them how to turn the patient, how to take care of the pressure areas, how to feed using a PEG tube. They'll also be able to show them how to change the linen. So that is very, very important. So next slide, please. Next slide.
It's on. The next slide is on.
Okay. Yes. So we can't also forget what the family is going through. And I've seen in the chat, most of you have said that we need to be them. We need to be present so that we can support the emotions. So this one cannot be underrated. I must say that here at Kenyatta National Hospital, we are lucky because we have a department. And in this case, we were able to bring the chaplain very, very early. We don't wait until we have done everything. And we know sometimes we have already seen the signs that this might end this way. And now that is the time we are bringing the chaplain to bring them very early. So for them is to support the patient spiritually, because at this point, at this juncture, that is what they need most. We also want to identify if they have some emotional distress that we can address before they go home. So we have to show a lot of empathy, and we must care and listen to them. We must also treat them with a lot of, and Professor Adam said that the nonverbal cues, they matter a lot. When we are communicating to these patients, how are we carrying ourselves? Are we available as they talk? Are we listening to them? So that all these things we are able to work with them, and we are able to align the goals of care effective and respect is true way, so that even as we involve them and teaching them, they also understand every aspect of care that we are doing. The other important thing is that this patient, ultimately, we are saying, is going home. So we must take care of care as they exit and they go home. And for this one, we must consult widely. Multidisciplinary team, we have the neuro, what is the plan of care as they go home, physiotherapist, the social worker, the nutritionist, they must go with diets which are planned. We also have the counselors who will continue supporting this family. So we have to bring everyone on board so that the patients can benefit and the family feel comfortable. Even as they go home, they will not go empty-handed. They'll feel we have enough information, we have enough knowledge to continue taking care of our patient. And I think with that, I want to end it there and back to the moderator.
Thank you so much, Mr. Ndungu. This was an excellent opportunity for us to see the kinds of things Professor Lefroy talked about in action in real life. We appreciate hearing from your experience. And now I'd like to transition to Dr. Irene Mboya. I want to make sure our tech team unmutes her. Dr. Mboya is a general surgery resident at the University of Nairobi, and she holds her degree in medicine from the same institution. Let me hand it to you for another case. Dr. Mboya.
Thank you so much. Am I audible?
Yes, you are audible.
Okay, thank you so much to our sponsors and to Acquire and the Society of Quality Healthcare for this opportunity. I'll quickly take you through a case, and then we can just have a short discussion on the topic of today. So my case presentation is on a patient, MW, a 71-year-old female who was admitted to a specialized unit, which is the burns unit, with a history of falling onto open flame. She fell onto burning firewood after a dizzy spell and sustained burn wounds to the left knee and part of the thigh. The patient was rescued by her relatives and then brought to hospital for management. In terms of comorbidities, this patient is diabetic, hypertensive, who had been on follow-up and was also on management for subclinical hypothyroidism. During admission, this patient was sick looking, had a low consciousness level with a GCS of 12/15. The other systems are within normal, but on local examination, we noticed that the patient had a deep partial thickness burns on the left knee. So the reason the patient was admitted to a burns unit was because, one, the patient is old, elderly, at the age of 71, has comorbidities, and had burns to major joints. In terms of management that was instituted, of course, there were the lab works that were done that showed that we have hyponatremia, hypothyroidism, a head CT scan that was done that showed the patient has an occipital meningioma, which may have been the cause of a low GCS, and the disease fell. So management was mainly non-surgical, although we also had periods where we had surgical management instituted. That means that we had, cardiac support, cardiac monitoring, neuro monitoring, nutritional support, wound care, because this patient had a wound on the left knee. Because of the burn wounds, there was formation of eschars. So that means at one point we had to do escharectomy for the wound. The wound was unfortunately at a major joint. So that means at some point in time, we had infection to the knee, and we had to involve the orthopedics team to come and do a debridement and a knee washout. During her stay, which was about 3.5 months or so, the patient developed gluteal pressure sores. So that means we had to continue the wound care. We had to do debridement of the same gluteal sores and repeat debridement for the wound and vacuum dressing. As earlier alluded to, patient care is always multidisciplinary. So that means we involved various teams in this patient's management. The neurosurgery team, because we had an incidental finding of an occipital meningioma. Cardiology team, because the patient was hypertensive and we had periods where the patient had low pressures, high pressures. Endocrinology, because the patient was a diabetic and also had hypothyroidism. Orthopedics, as I've said, and plastic surgery being the primary team of management. And nutrition, because our patient, remember, at admission had a low GCS. So that means in terms of feeding, we may have had to put an NG tube or TPN or something like that. Physiotherapy, because we have to make sure that our patient doesn't develop other sores. And of course, we can never forget our nursing and psychology team as well. So in terms of the difficult discussions we had to undertake with the family of this patient, and not the patient herself, because the patient's conscious levels was very low. So that means the family was our contact all time. So the questions that were raised by the family would be questions such as, why are we not operating on the brain tumor? So such discussions, as Paul and Professor Janet has already alluded to, family conference is the best way to be able to provide information that is accurate. And that means involving the neurosurgery team to do the family conference and inform the family or give the expert opinion on why we are not managing the patient surgically or why we are doing non-surgical management. Of course, this is also doing so by ensuring that you know what the patient's family already know about the condition, and then educating them or providing more knowledge on the same topic. As Professor Janet correctly said, you can also use images or written information at such cases. So the other question raised was, why does our mother need several surgeries for the burn wound? If some of you have gone through a burns unit or a burns ward, you notice that some of these wounds do not heal immediately. Sometimes you have eschars forming, you have infection that happens, you change from one dressing material to another. So that means that at times you may need surgical management more than conservative or the wound dressing. So explaining that to the relatives for them to be able to understand why you're choosing surgical management over conservative management or just wound dressing at each point is very paramount. And also being empathetic and providing information that is accurate to them. So why is she not recovering despite treatment and surgery? As said before, always have family conferences at the beginning of treatment and every other time as needed, so that the family, the relatives of the patients are up to date with your plan, which will also help them to be able to see why a certain treatment or a certain surgical procedure was not working or is working well. So in terms of this patient, you've already said that the patient was an elderly patient, had comorbidities, had burn onto a major joint. So there were several factors that were compounding our situation here. So explaining to the relatives why our patient is not healing well despite treatment and surgery is very important, and enabling them to understand why we need their continued support and cooperation for the patient's treatment. So when will she be discharged? If you're doing your family conference regularly as needed, then you'll be able to explain to the family why our patient had been in hospital for 3 months and why discharge was not anticipated at a certain point. So what happens if the patient will not be discharged soon? So remember that our patient and her family are also incurring financial burden. There's the emotional burden. There's the trauma of the hospital, experience and everything. So being able to provide support for the family, which will be in terms of psychological support, spiritual support, as Paul already alluded to, ensuring that they have, insurance, finding out how they're going to pay the hospital bill, if they need help, linking them to a social worker so that they don't feel burdened even as they continue to care for their relative. So in terms of what is the next step if the patient is unfit for theatre? So sometimes, even as doctors, we may do our best, but situation doesn't allow us to achieve the outcome that we need. So we should be able to explain to our patient, like in this time, at this point, we involve the anesthesia team, the surgical team, all the surgical teams to be able to explain to the relative why at a certain point in time, our patient was not fit for surgery. And that would have been maybe because of anesthesia risk, because of sepsis, because of just the patient state at that point. And all these helped us to be able to keep in touch with the relatives, to be able to provide emotional support, psychological support, and spiritual support for them. And we noticed that through all this, the relatives were very cooperative. Although unfortunately our patient did not make it, but because we involved the relatives at all stages, the relatives were able to see the journey through why the patient did not make it and accepted it. And as Professor Janet already alluded to, during the family conference to break down, give them the bad news that the patient had not made it, we used the SPIKES acronym to be able to deliver our news and be able to be empathetic and listen to the relatives. I think for today, that's all I'm going to say, and I'll give it back to the moderator.
Thank you, Dr. Mboya. What an excellent and complicated case. Audience members, as you are writing your questions in the chat, in the Q&A box, we're going to move into a live Q&A session. And I'm going to start being the moderator with the option of posing the first question. And I'd like to hear from both Professor LaCroix and Mr. Ndungu. And as you respond, would you please undo your video so we can see you as well? Now, the case Dr. Mboya presented is one we all too often face, which is difficult conversations that evolve, in this case, over 3.5 months, with many, many different teams, multiple consultants, and an untotaled number of actual healthcare providers. First, Professor Lefroy, how do you deal with the complications that come with having so many multiple teams involved?
Thank you for the question. And I think the things that are really important here is the P of spikes, so to know what people's perceptions are at each point. So as the time goes by and different teams have been involved and said different things and given different prognoses and hopes, the understanding of the patient and their family will change. And so when you come in at a certain point, you need to know where are they up to, what do they think the situation is now, what have they understood. So always asking questions before you start explaining the next bit of information, I think, is really important there. And secondly, I think both the cases gave us the strong feeling of how important the family and relatives are. So in Irene's case, the patient was in hospital, but the family were still very important. And for Paul's case, the family were going to need to take this patient home and be the main carers. So realizing that we need to explain things maybe to multiple people, not just to the patient. I think probably in Kenya that's more understood, that the family are always around. We quite often have times where the family are not allowed on the wards, it's just the patients. And that's when the ward round is done and things are said to the patient, and the family turn up later and there's no doctors to be seen. And that's not good. The family need to be involved and to understand the position. And often family and relatives have strong emotions themselves, sometimes even stronger than the patient. The patient is accepting that they're not terribly well, they feel not very well, they can understand that things are not going well, but the family don't always accept that. We want our mother back, we want our son back as he was before. And so they need to be listened to, and that needs to be acknowledged at each stage along the way. And finally, I think the important thing is to build trust. So they are putting their patient in your hands, their relative in your hands, themselves in your hands. And one thing I always remind myself and remind my team is that we are here for our patients. And sometimes I will say that to the patient or to the relatives, we're here for you. And that helps them maybe to trust that you're really caring and really thinking about them. And it's with a patient who's at the end of life, I will sometimes say to them, you're a VIP, a very important patient. So we're going to look after you extra well because you're at the end of your life. And people laugh about that being a VIP, but I quite like to say that. Thank you.
You know, I see some hands clapping in acknowledgement of that. What a wonderful idea. Thank you for that. Mr. Ndungu, we want to hear from you. How do you manage this when you have such complex conditions and multiple care teams? Please unmute and share video if you're able. Let's hear from Paul.
Thank you so much, Mary. And I think I want to emphasize again what Professor has said, that when we are dealing with multiple teams, the most important thing is that we are all in agreement. At this juncture, the family is looking to whether all these medical teams, are they all in agreement? In my case, this patient KK, we are saying is for home-based care. Is that coming out across all the people who are taking care of this patient? So one of the most important things for them to gain our trust is that the message we pass has to be the same and very consistent, very factual. What team A has said must correlate with what team B is going to say. The other thing that is very, very advantageous, especially for us who work in tertiary hospital, is that the nursing team is every time in the ward. They are there throughout. And for them, there is always a team leader. And this team leader coordinate on these other disciplines and coordinate the care of the patient so that it is seamless from point A to point B. If there's anyone who needs to see this patient and has not been able to come, the nursing team is able to look for them slot for them so that they can even have a sitting with the family. So that is very, very key. And I think that worked well for this case. The other important thing is that even as we continue taking care of this patient, the information we hand over, it must also be very consistent. And the things that are pending, we must always see, are we in a position to do them in the next shift? Do we allocate them time so that they can be cleared? And the patient, the family doesn't see like we are taking a lot of time, yet we are doing so little. Thank you.
Thank you, Paul. I'm going to ask you to stay live because, and stay unmuted and on video. I'm going to take the first question from our live Q&A session and direct it to Paul. So, Paul, Charles Barassa asks, how long can one take after breaking bad news for the patient to come for more clarity? And they're talking about managing these emotions. Paul, how long does it take for patients to sort of understand? What are your thoughts?
I think I want to say again that communication is very, very key. How have we been communicating all along with these patients? And even at this juncture whereby we have bad news, it is going to build into what we have been communicating. And sometimes people may take wrong because emotions are there, and we accept that people mourn, and we all mourn different based on the information that we get. So even as we break this information, we are also assessing what is their level of understanding. What do I need to reinforce so that we can make this issue of either in the stage of mourning, either in stage of denial, so that it is managed properly. So it is very, very, very key that we must always get their perspective. From their perspective, we align with what we are going to share with them. And for us, we always say patient-centeredness. When we are patient-centered, it means we focus on what is important to the patient and not us. Even if we are 1,001 disciplines or people taking care of these patients, it is not our show. The show here is the patient that we are taking care of. Thank you.
Thank you, Paul, for that answer. As I'm looking at the Q&A, I see that multiple people have asked for the slides used in this presentation. I'd like to refer our audience to the chat box where there's a PDF of the slides and the presentations present for you to be available. Let's go on to our live chat Q&A. I'm going to point this question to Professor Lefroy. Elizabeth asks, having multiple teams more and more, is this charges to the patient? We might be able to unmute Elizabeth so she can ask her question directly, because we'd like to make sure we're understanding you. She goes on and says, does the primary control the duration of team involvement? E.g., can the team lead request some to drop when their care is no longer needed? Janet, I'm going to hand that over to you and ask Elizabeth to be allowed to unmute to make sure we're getting her question clearly understood. Janet, go ahead.
Yeah, I think this is a real issue, isn't it, in real life, that teams don't always communicate with each other all of the things that they're thinking about a patient. So one team, for example, if you've got a patient with cancer, maybe the oncology team are still giving them chemotherapy, and you're looking at your patient and you're thinking, you're getting near to dying. You know, we ought to be talking about end-of-life care and maybe changing priorities here. And sometimes you're too busy to actually pick up the phone and talk to the oncologist, or you think it's, they're the expert, it's not my place to question what they're doing, but the patient is the one who feels that people are not talking the same language, not giving the same messages, and they get confused. So it's a really important question that you're asking there. And I think, yeah, it is really helpful if people can hand over care to another team and say, over to you, but please come and ask me questions if you need to, about, medication or whatever. And in reality, that doesn't always happen. So maybe if we care about our patient, we can see that it matters to know what stage everybody thinks they're at, then those conversations or letters, messages need to be sent. Does that answer your question?
Elizabeth, is that helping you understand? They may not be able to unmute her. Elizabeth, type in the chat box. We'll be watching to see what we can discern to make sure we're addressing that. I'm going to ask Paul to start with the next question, and I want to hear from both Paul, from all our speakers, Paul, Irene, and Janet. Florence asks, how can we handle healthcare worker bias that might arise during these difficult conversations, sometimes resulting from our own negative experiences or cultural beliefs? Paul, I'm going to ask you to unmute and share your screen so we can see you. This is a fascinating question. How do we address our own negative experiences or cultural beliefs in these settings?
Thank you so much for this question. And I think I want to thank the person who has asked that, because for us as healthcare workers, sometimes we come with our own biases into the care. But I think for this case, and I think for the most important thing is to ask ourselves, what is the goal? What is the goal for this patient? What care does this patient need, so that we may eliminate our biases? The other thing is that also the multidisciplinary team helps, because our views might be divergent, but at the end of the day, we must agree what is the care that this patient needs. Like I said, when we look at, when we generalize this and narrow it down to being patient-centered, we ask ourselves, what really matters to KK, or what really matters to this person here? And when you ask yourself those questions, then you are able to deal with your own biases. And it is also very good when you get the self-awareness that you have personal biases, then that is a chance that you are saying, then I need to pass else, because I think for me, I'm not the best person placed to continue taking care of this patient. Thank you.
Thank you, Paul. Dr. Mboya, we'd love to hear from you. You are still early in your training. Are you seeing cases where people come in with biases, and how are you seeing that addressed in ways that you'd like to copy or emulate as being better ways to deal with it? Please unmute and share your screen if you're able.
All right, thank you. I think we've all had experiences where our colleagues in the healthcare system have had biases that they've expressed to us or to the patient. And the first thing I would say is accepting that while you're working in the medical field, you're going to be working with people from various religions, ethnicities, races, and accepting that patient care should be equal for all patients. So that means if you'd had a bad experience, we probably need to accept your experiences or address your emotions and not project that to the patient, because that will be, it will affect the patient care that you provide. And then the other thing is accepting that once you get to your working station, the patients that you are supposed to take care of are patients who are going through a difficult situation and they need support from all of us. So being able to be supportive, empathetic, being professional as well would also impact our patient care. We are all aiming to provide, evidence-based quality care to every patient and to be fair and equal to them. So addressing such issues, and as Paul has said, in case you feel that you have cultural biases or whatever bias against a patient situation, then it will be a good decision to step back and allow someone else to be able to provide the best care for that patient to get the best outcomes. Thank you.
Thank you. Let me hand this back to Professor Lefroy. Janet, we know that you're currently based in the UK, but you've had extensive experience in East Africa. Do you see this in the UK where cultural biases or past experiences impact? And do you see differences between what happens in the UK and what you've seen happen given your experience in East Africa?
Okay, thank you. Certainly, I think bias is something that affects us all, and we're unconscious of our own biases. So it is really helpful to discuss a situation, a patient's care with colleagues, and then if you're surprised that other people have a different view to yourself, then maybe that suggests that you've got some bias. Now, as I get older, I'm more and more aware that what somebody else would call bias, I call expertise. So the expert is the person who makes the same mistakes with increasing confidence. And we need to be humble that maybe we're thinking we know best. And patients, certainly here, will sometimes say, "What would you do, doctor, in my situation?" And I think you really have to hold your tongue and not say what you would do in that situation, because you are not them. So just to remember that we're trying to help the patient to make the best decision for themselves, and to discuss it. If it seems to be that it's not quite clear what is the best way to manage things, then discuss it with colleagues, and often the biases will just recede because you realize that's because I had a bad experience of having that particular procedure done, so I don't think my patient should have it done. But actually that maybe that wasn't the right thought to be having. The comparison between here and East Africa, my East African lived experience is actually quite a long time ago now. 23 years ago, we left Tanzania. So I think so many things have changed that I can't really comment. I feel I'd be really interested to know whether what I have said seems to resonate with and help the East African situation, because we're all human beings. And I know when I was in Tanzania, you didn't break bad news to a patient. The patient was the last person to hear about it. It was the family would maybe be told, and then they'd be told not to tell the patient. These sort of things happened, which I think probably it's much less like that now. And it used to be like that here. And we have discovered that actually the patient owns their own information, and so they have a right to know about it unless they say, "Please don't tell me."
Thank you, Professor. Paul, I'd like to ask you to respond to that. Do you think things have changed in how much information is disclosed directly to patients over the course of from your student days, like Dr. Irene, to your current days, where you're functioning in a high level of management and responsibility? Share your views on this cultural aspect.
Oh, yes, I think a lot has really changed. A lot changed. I think as years have gone by, most of us have become more aware. We also know that the healthcare landscape has also kept on evolving to being better. So there's a lot of things that people are now aware in terms of confidentialities of patient information. There are also which have become on data protections. There are things which have also come in terms of how do we deal with our patients. So they have evolved. But again, when you look at the cultural aspect, I think we also respect that so much. And where wishes are expressed, we respect them. Either the patient doesn't want to know and the family wants to know. The family wants this information not to be passed by this. And we sort of have conversations so that we can to disagree. But I think we also, a lot of awareness has raised because the people we are also dealing with are also very, very informed. They also are able to Google information and get. So even as you share with them, so you are also aware that they could be knowing much more than you think you know. So those are some of the things that have evolved in the system. Yes,
I'm sorry, please continue. I was just impressed by your comment from Dr. Google. Things have radically changed when patients come with their Dr. Google information correctly or incorrectly understood or applied to the context of their own care.
Oh, yes, and that any piece of information that we share or we are going to discuss, then it becomes very, very sensitive because we are also conversant that social media is also there. So anything you may say or anything you may do, you might find it in those media. So thank you.
Yeah, it is a challenge. As I'm looking at the Q&A questions, I'm struck by how many are asking questions about breaking bad news to children. You know, I'm a pediatrician, and so I very much care about how we address the issues of children. Professor Lefroy, when you're addressing children, is there an age where you think it's appropriate to break the bad news to the child? How do you deal with that?
Yeah, I'm trying to think whether I've had to break bad news to a child. It's not such a common thing for a family doctor to have to do. Maybe the bad news I'd have to break would be you've got to take a week off school for this illness, or you've got to go into hospital. I would usually want the child to be in the room when the bad news is being broken to them and their parents, unless I think that the parents are not going to handle it well for the child. So I'll try to gauge that situation. And children usually, I think maybe you should answer this question yourself, Mary, but children usually do accept what happens to them much better than their parents do. They accept it and cope with it. And it maybe helps the parents to see that the child is accepting it.
Well, thank you for bringing that up. I do think children know much more than their parents sometimes suspect. They certainly know what's obvious. I'm having to go back to the doctor a lot. Something about my body has taken away my energy. And I think bringing children into the conversation, framing those issues in ways that are appropriate to their cognitive age and stage. Where I think we as physicians sometimes miss opportunities is when we're dealing with these 12, 13, 14-year-olds. The tendency for parents to want to protect children from bad news often then even backfires, particularly as Paul was pointing out in this active age where kids with a phone can find out all kinds of stuff, and they hear words, and all people hear whispers. They know that something's being said and they're being excluded. And so I think as we think from a research ethics framework, you want to be able to get their assent. That implies a level of understanding, and things can be framed in ways that fit that cognitive space. I see Gregory asks specifically about ages of breaking bad news. There are ways where I think you can put some precautions in place. One of those, honestly, is to practice. Practice saying things with a colleague and say, do you think that'll make sense to an 8-year-old? Then talk to the parents and ask them, do you think that will make sense to your 8-year-old? And allow parents to invite you and the child together into that conversation. I'm going to continue and take another case from another question from the Q&A box. I see Kifa asked for clarification on the touch regarding what not to do. Professor Lefroy, can you share a little from that? We don't need to pull up the slide necessarily, but what are things not to do? We focused on the positive, but what not to do is worth thinking about again in review.
Yeah, thank you. And I don't want to discourage you from touching your patients or their relatives if it's appropriate. And these things are often cultural, aren't they? What is appropriate? And I'm quite a touchy sort of person. I quite like to put my hand on the patient's hand or on their shoulder, hold their hand. And for me, I think that would be comforting if I were the patient, but you have to look at the reaction you get. So what I was talking about there was in a situation of conflict where you are, people are feeling stressed, angry, irritated, you're getting challenging communication from them, then touch is usually not helpful in that sort of situation because they won't perceive you as being comforting and calming. They'll perceive you as maybe laying hands on them and it's an aggression rather than a comfort. So that's the situation when it's best not to touch. Just try and get them to sit down if they're standing up and shouting at you. Say, let's sit down, but don't push them down into the chair. Don't drag them down by you sitting down yourself. So try to avoid touching in those sort of situations. But I wouldn't want to stop you touching your patients or relatives as a sign of comfort. And of course, there's therapeutic touch where you're doing a pressure point or whatever, and there's examination touch. So we touch our patients a lot, but you have to think, why am I touching them? And is this a helpful thing?
Thank you, Professor. Dr. Irene, I see a question in the chat box about the family conference and how it's done, physically or virtually. As you're unmuting, can you share, because you talked in your case about family conferences and how you do it, and then have you ever done them virtually? You know, we're all in the post-COVID season, and I'm curious about how that might have worked.
All right, thank you. So currently, I haven't done a virtual family conference yet, but I have been in a situation whereby a colleague has had to do that, especially if some of the patient's relatives are not, close and they cannot make the travel from wherever they are to come and comfort the patient or come and ask pertinent questions about the patient's treatment. It all depends on the comfort or the choice of the family. Because we have to tailor our treatment or our plan to what the family and the patient needs. So in case a patient's loved one, who the patient chooses to know about their illness is not around, then you can just organize with the necessary teams and hold a family conference virtually. In most cases in our setup, we end up doing them physically. So when the patient is being visited, we talk to the relatives, we say, we have these updates about your patient, and who else would you like to be there for, the family conference as we give this information. So they usually end up coming later in the evening or the next day, as a family of 2 or 3, and then we have a sit down in a safe place that is safe for the medical provider, that is safe for the patient as well. We understand that emotions can run high and you cannot control emotions. So we also have to ensure that the provider is safe while delivering this, bad news or having these difficult conversations. And then in terms of setup, we've talked about the space or the office. The other thing is the team, the medical team that you need on board. So in case you're having a multidisciplinary case, then you approach all the necessary teams to be there for your family conference. And then the relatives or whoever the patient has chosen as people that he or she needs this information to be given to. And then as Professor Janet already alluded to, when you're doing your spikes, it becomes easier once you know what is the next step. So once you've set up, you look at the patients and the medical providers' perceptions, especially the relatives about the illness. What do they know? What do they want to know? What do they need clarifications on? And then you invite them for the questions, let them ask the questions, whatever number of questions it is, and then just respond appropriately, accurately, and with expert opinion so that you're disseminating knowledge that is accurate. And then after that, you just provide the knowledge that is necessary. As we said, no medical jargons, whatever is the language that is understood to the patient and to the relatives. And then just
Excellent.
Yeah.
Thank you so much. As we put up the final slide to share with everyone, I want to get a shout out or a clap from you guys for our excellent speakers. I have to say that the time has flown by. I am sorry we weren't able to get to all the questions in the chat box. But I do want you to know that opportunities to continue to learn together are going to be present. We were delighted as a choir to have these excellent speakers, to be able, together with the University of Nairobi and Kenyatta National Hospital, to bring to you this topic on managing difficult conversations. If you're interested in QI things, we'd love to have you take a look at the Acquire What's Up channel and find us on LinkedIn. With that, I'd like to ask our speakers to put their video on and give us all a wave goodbye. And we so appreciate having each and every one of you as participants on this webinar today. Thanks again to our tech team. Thanks to Kenyatta National Hospital for the platform. It's been very much appreciated. And most of all, thanks to our excellent panel. We appreciate you.